got this pop-up and it's not coming off for some reason. All right, give me 1 second. Let me just fix this. Can folks still see my slides?
No,
No.
I don't see it right now.
Yeah, we lost the share screen. We just,
Let me try it again. It should be fine now. There's a pop-up that I was just trying to get rid of. How about now?
yes.
Okay, perfect. I'll make sure people can see my video too. I'm ready whenever.
Great. Pratt, was there somebody set to introduce Haider? If not, I'll do it.
I don't see them on, so I'm not sure. But if not, yeah, if you could do it, Dr. Bonner, that'd be great.
Yeah, so in the interest of time, we're really delighted to have Haider Warraich here presenting to us today on palliative care and heart failure top 10 tips. He's really been, despite being an early career, really been a phenomenal leader here, highly published, currently assistant professor at Harvard Medical School, associate physician at the Brigham and Women's Hospital, also associate director of the heart failure program at VA Boston Healthcare System, has really collaborated with many on really trying to highlight this, such an important area for our advanced heart failure patients and considerations of palliative care and what the trends have been nationally in the use. And we're just delighted to have him here at UCLA to present to us. So Haider, let's turn it over to you.
So thank you so much, Greg, for the introduction, and it's so great to be speaking to you all. And I'll get right into it. You know, the idea behind this talk was really to have tangible tips that I can sort of share based on my research and looking at other people's work to think about how we can best provide palliative care for patients with heart failure, with advanced heart failure, especially as they approach the end of life. I have no disclosures, and I'm gonna just jump right in. So I think before we get too far ahead, if you look at the overall landscape of heart failure, really, a lot of times, when I was trained as a heart failure fellow, most of my training was focused on LVADs and heart transplant, etc. But if you look at the overall distribution of patients with heart failure, those patients comprise a very, very small number of patients in the larger pool of patients who have heart failure. And then even within that pool, half of our patients have HFpEF, for which even though we now have some therapies that are promising, we still don't have the bevy of options that we do have for patients with HFrEF. And the other thing that you note is that if you look at the number of patients who are hospitalized with heart failure, these are data from the National Inpatient Sample, about almost 40% of these patients are greater than 80 years of age. So they would, just automatically not be candidates for any of those advanced therapies. And this is also reflected in data from death certificates in which we're looking at people who are dying of heart failure. As you can see, most of these curves, these are again people who are dying of heart failure in the US. Again, these are undercoded, but gives you a sense that it's really this purple line at the top, which is people who are over 85, in which we're really seeing the majority of growth in the number of patients with heart failure. And the reason this is important is because so much of that this is really population that is generally much older than average patients and really has a geriatric syndrome, and so would be someone that we should consider palliative care strongly for. But before we answer that question, I think the first question that any clinician would ask would be, how effective is palliative care for patients with heart failure? This is I think especially pertinent because if you look at the history of palliative care, if you look at the history of hospice, they really started with cancer patients in mind. So the question really is, how well do they translate to a population of patients with heart failure, which is very, very different. So this slide is a compilation of randomized controlled trial data that has been published in this space. And what you'll essentially see is that really across the board, palliative care is associated with improvement, certainly in symptom relief, in quality of life, as well as mood and other sort of quality of life based metrics, with some studies also showing a reduction in hospital readmission as well. So it is a therapy that is outside of cancer, is the best studied setting for palliative care. And if you look at meta-analysis data, so this was a paper we published last year in which we looked at palliative care trials, randomized trials in non-cancer conditions. And if you compare heart failure to other non-cancer conditions, such as, say, COPD, for example, palliative care is associated with reduction in heart failure in overall hospitalizations in heart failure, but not in other conditions. So it's probably even more effective in this indication than it is for patients, let's say, with dementia, COPD, etc., which was in the other group. And not only is there an improvement in hospital admissions, there is an improvement in the number of patients who have an advanced care plan, and certainly that can help with patients making decisions and can improve the quality of care that they receive at the end of life. There are many other outcomes that palliative care has been shown to improve. Palliative care interventions are associated with an improvement or the increase in the number of people who are able to die at home. We know that being able to die at home is something very important to most patients based on survey data. So that's certainly a metric that is pertinent. Early palliative care is actually even more beneficial, and the earlier the intervention is deployed, the more likely this patient is to die at home. There's a reduction in terminal hospital and ICU use. And another important thing is that, a lot of times there can be discordance between how a patient might think about their survival and a clinician, and palliative care can really bridge that because of more effective communication. And it is because of all of these sort of evidence that both in the European, this is the European guidelines, but also in the ACCHA guidelines, palliative care is a class 1 indication for patients with heart failure. Now, despite the evidence and despite the support by guidelines, we performed a study that this was from a national registry of palliative care referrals, looking at patients with cardiovascular disease to see where have these patients been referred from. You can see over time the proportion of patients referred from general medicine does improve. There's a slight improvement in patients who are referred from critical care. But when it comes to cardiology, not only do they account for a smaller proportion of referrals, but that proportion is actually going down over time, suggesting maybe that we've not done a good enough job as a specialty and as a community to really get palliative care or cardiologists to get thinking about referring their patients for palliative care. Now, what I'm going to do here is share some tips that I hope that are based on my experience and some research that I hope to make this a bit better, to sort of share some palliative care principles and how we can incorporate that into a routine practice for patients with heart failure. So I think one of the main challenges that we face in patients when we take care of patients with heart failure is that prognostication can be extremely difficult. I'm going to share a case here. It's going to be brief. And this is a case of a 40-year-old male who feels dyspnea with exercise, has a dilated cardiomyopathy with an EF of 20%. The vitals are right here. These are the lab values: sodium of 129, white cell count of 6.3, lipid profile. These are the patient's meds. And the question for the group is, what do you believe is a patient's mean life expectancy? So I want you to come up with a number in your head, just a random number for this 40-year-old patient with an EF of 20%. And if you plug all of these into the Seattle heart failure model, which again is not perfect, but it is something, this is the value you get, which is 4.6 years. Just keep these data in mind as we go to this next case as well. Here's another case. This was a 79-year-old woman who had dyspnea at rest. She had HFpEF. These are the patient's vitals. You can see the labs. Kidney function is normal. white blood cell count is 8.4. Meds include atorvastatin, lisinopril, Lasix. And now the question is, what do you believe is this patient's mean life expectancy? And I would like you to come up with a random number, or not a random number, but any number that you think makes sense for this patient. And here is what the Seattle heart failure model will tell you. Now, what we did was we took these two cases as is, and basically gave them to around 350 clinicians at our hospital. This is when I was in residency. And we gave it to people who were in internal medicine, people who were in oncology, and people who were in cardiology. And there was a control case, which is a cancer case. And we just wanted to see that if a broad sort of array of clinicians were to look at these cases, what their estimates would be. And we essentially defined an accurate survival extremely loosely. We said that if you're within twice or half of the estimate, we would consider you accurate. So for the first case, if you're between 2 and 8 years, you would be considered accurate. And for this case, if you gave an estimate between 1 and 4 years, you would be accurate. And so these were the results that we published. You can see that lung cancer, the accuracy rates were fairly high. Red is medicine, black is oncology. They were more accurate than cardiology, but generally more accurate in general. When you look at the HFpEF case, which is your second case, only less than 50% were accurate. Less than 50% gave an estimate within 1 and 4 years. And when it came to the HFrEF case, cardiologists were much more accurate than the others. The reason cardiologists were more accurate was because the other specialties were actually too pessimistic about this case. Now, usually when we think about prognosis, we think about that we as physicians are too optimistic about prognosis. But when it comes to HFrEF or people with low EF, it seems like we focus too much on the EF and forget other aspects of the case that might be going on. And this is actually something that affects patients quite considerably. So these are data that are in a review right now. This is an analysis from the Health and Retirement Survey. And this looked at all patients who were dying of cancer and who were dying of heart failure. And they interviewed their caregivers to see if they felt that those patients' deaths were unexpected or not. When it came to cancer, only about 18% of those deaths were considered unexpected. These are several thousand patients, so we have a pretty decent sample size here. But when it came to heart failure, 50% of caregivers felt that the death was unexpected. Now, it is true that some patients with heart failure can have sudden cardiac death, but we know from studies that the rates of sudden cardiac death in heart failure are actually going down considerably. So in my view, the reason why this is so high is because patients and clinicians are not on the same page, and patients just don't think about heart failure the same way they would cancer or other life-limiting illnesses, which is why 50% of all deaths in the Health and Retirement Survey from heart failure were considered unexpected. Now, how can we do better at estimating prognosis? This was a great study led by Larry Allen, which showed that if you use some of your standard risk calculators, such as the Seattle heart failure model or the MAGIC score, and if you just look at 1 year risk of 1 year mortality, their sensitivity and their positive predictive value is actually quite low. So the question is, yes, these models may be able to help you on a population level, but are they actually helpful at the bedside? Are they actually helpful when we are making important clinical decisions? So to address that, this was another study that was very interesting, and this is the approach I use. And basically, what you can see here is that based on what category you are in, this is a very good discriminator of mortality. The question is, what is this? Well, this is very simple. This is what's called the surprise question. So if you are in oncology or if you're in palliative care, the surprise question would be something that's very familiar with you, but for cardiology, it isn't. And really, it's very, very simple. It is you basically asking yourself or the medical team, would you be surprised if the patient passes away within the next year? Simple as that. So and what this shows is that clinical intuition is actually quite powerful. And it's not just the physician's intuition. Here, now we take the results of the surprise question and actually have them below the Seattle heart failure model. And really, it's not just the cardiologist, but it's the heart failure nurse, very high sensitivity, that if they think that the patient has, they wouldn't be surprised if the patient died within last year. that can be very sensitive. And actually, if you pool the results for all the team, you actually get an increase in the positive predictive value. So this is something that I use oftentimes when I'm helping just our teams think through, is the patient ready for palliative care? Is hospice reasonable? How do we sort of frame this question? And I'll just ask this question that seems very, and this is how I communicate prognosis to my patients too. I don't tell them how long I think they have to live, but I tell them that if I were to get a call within the next year that Mr. Smith has passed away, would I be surprised? The answer would be no. And I feel like that is a kinder, gentler way of sharing how I think about someone's survival, because we know that that can be something that can be very that can cause a lot of people distress. So the second tip I want to share is about having thoughtful discussions about ICDs in terminally ill heart failure patients. Now, the reason this is important is because, we are lucky in heart failure in that if you look at, for example, cancer or chemotherapy, most therapies make you feel bad, but they might increase your lifespan. But in heart failure, almost every therapy that we have, from CRT to SGLT2s, they all don't just improve mortality, but they also improve quality of life, except for ICDs. And I think for a lot of, and what we also know is that a lot of patients who have heart failure are likely to get inappropriate shocks with ICD therapy at the end of life. So one way that I discuss or I share information about ICDs is by using the Colorado Program for Patient-Centered Decisions. So patientdecisionaid.org is a group led by Dan Matlock, who's a geriatrician. Larry Allen is a heart failure cardiologist who's part of this group, and they have some great tools to really explain to patients and walk them through some of these difficult decisions. Most of these are randomized trials, studied interventions. This is their data. This is their sort of figures for ICDs, and I find them to be extremely useful. So this is a great resource that I often apply for patients who are mulling some of these hard decisions. And as you can see in this list, it's actually pretty thorough. So there's a lot of other interventions as well that if you're interested in sharing these, this is a good resource for you to remember. And really, the reason why this is important is that if you look at the natural history of someone who has heart failure, there's so many important decision points. There's so many inflection points that they can face with regards to needing procedures, or having worsening outpatient heart failure, or having a hospitalization or an ICU admission, that really there's so many places that I think that we probably need to pause and reevaluate what might be important for a patient, and just to frame where they are in their illness. Another tip, and probably if this is one of the most important tips that I have, I think a lot of times the question often comes up is that, well, what is the right time to consult palliative care, or what is the right time to start thinking about palliative care? And at least all the data suggests that the right time for palliative care is probably earlier than when you thought about it. And so to look at this question, we looked at this study this is a national registry of patients who were referred for palliative care, includes both outpatients and inpatients, community hospitals and academic centers. And this included about 1,800 patients who were referred who had a primary diagnosis of cardiovascular disease, who were referred for palliative care. Their mean age was about 78%. Most of them were hospitalized. And as you can see, about 50% for DNR, DNI at the time of consultation, but that increased to around 70% after. So certainly just that data point alone is helpful. And one of the ways that we look at whether the timing of palliative care was early or late or appropriate was, what is the functional status of the patient at the time of referral? So the way that we do that or assess that is by using something called a palliative performance scale. And if you compare patients with cardiovascular disease versus patients with cancer, 30% of patients who had cardiovascular disease were actually bedbound at the time of referral, compared to only about 19% of patients with cancer, suggesting that we are delaying the decision too late to refer to palliative care. So that's just so the way I think about incorporating palliative care into the sort of life course of a patient with heart failure is, let's say that this is you have disease burden on the y-axis, higher is worse, and then you have time. You have a patient who is initially diagnosed with heart failure. They have this chronic stable heart failure phase, which can last for years to decades. And then you have this more advanced heart failure phase, which is often characterized by repeated hospitalizations and other signs of advanced heart failure. And really the way to introduce palliative care is not just at the end, but gradually over time. And initially, this can happen just from the primary team itself. This is the cardiologist or the NP or the PA who's taking care of the patient in the inpatient setting. And what might that look like? Well, initially, of course, when a patient is diagnosed, you're focused mostly on the diagnostics, the therapeutics, etc. But then it's really in this chronic stable heart failure phase where we're implementing GDMT and thinking about ICDs and CRT that we can start thinking about, are those therapies aligned with the patient's long-term goals or not? And we don't have to consult palliative care for this. I think this is something that we as cardiologists can and should be able to do on our own. And it is only in this last phase when patients get sicker that secondary palliative care, which essentially means getting a referral from a palliative care specialist to come see the patient, who can then help with more aggressive symptom control, or talking about ICD deactivation or palliative inotrope use, etc., or thinking about whether medications need to be discontinued, and also hospice as well. So I think really the critical phase for patients to start, for us as clinicians to start introducing concepts of palliative care is actually in the earlier phase, because if we wait too late, then we may have missed some of that early window. Thinking about, well, what type of referral criteria should be incorporated to think about who should be referred for palliative care. And there's really two different ways to think about it. One is a needs-based criteria, in which you can think about, well, what is the patient's symptom burden? What are their physical or emotional symptoms? What is their functional status? Do they need help with decision support? If they have a lot of caregiver distress, etc. So you can either use this, or you can use a more disease-based criteria in which you look at you instead of focusing on the specific symptoms or burden, you focus on how advanced the disease might be based on whether they're having repeated hospitalizations, whether we think whether they kind of they score positive on the surprise question, whether advanced therapies are being considered. I mean, for me, some of the most concerning signs and symptoms in a patient with advanced heart failure is inability to tolerate medications, worsening end organ function. Cardiac cachexia almost always seems to be one of the most negative prognostic signs, need for inotropes, etc. But I think from a programmatic perspective, I think what you want is a broad enough criteria that every patient should have access to palliative care. Now, this is another tip, which is that heart failure patients may have many burdensome symptoms beyond dyspnea. I think in cardiology, especially heart failure, we become so focused on focusing on dyspnea and focusing on volume status that we may sometimes have tunnel vision and forget that these patients can have a lot of symptoms beyond just some of the classic cardiac symptoms we think about. So this is from that same study that I've mentioned before, looking at essentially a national registry of patients with cardiovascular disease referred for palliative care. And these are patients. This is the prevalence of moderate to severe symptoms in these patients, and this is poor well-being is probably the most common. Fatigue is very common. Poor appetite. Pain, again, is not as common as it is in cancer, but certainly a fifth of our patients have moderate to severe pain. But then you can see that there's a host of other symptoms as well. So focusing simply on dyspnea may not be enough, and that's why I think having palliative care who is more adept and facile with some of these other symptoms might be helpful. Now, this is another interesting sort of graph, and before I go into it, one of the other next questions is, well, what happens when these patients are even more advanced? Let's say when they go to a hospice setting. So, and what are the symptoms that we need to be worried about there when we're sending someone, for example, to hospice? To answer that question, we did a survey of hospice nurses, and the first question we asked them was, well, what are the most common symptoms that your heart failure patients have? And these are the gray bars. So you can see that these numbers look very similar to what you'd expect. Dyspnea was almost universally present, leg swelling was present, fatigue was present, but then anxiety, maybe something we don't really classically think about, was also very, very common. And then we reframed the question. We asked the same question, now asking, well, what are the most difficult to manage symptoms for you as a hospice nurse taking care of a heart failure patient? And now the distribution is quite different. You see that fatigue becomes the most common symptom. Anxiety becomes very common. Depression becomes common. Confusion, ascites. So this to me means that, we might be missing some of these other symptoms that these patients have. And again, I think that if we're not working closely with our hospice teams that we're sending these patients to and not training them to take care of all these other symptoms, we might be missing a beat there. Now, this is a really, really important piece, and I'm so glad that Greg is on, because I know that he'll appreciate this. The point is that many heart failure therapies improve symptoms and quality of life, not just survival. So I know when we think about palliative care, or when we think about palliative care systems, most of them have come from the cancer space, in which the therapies don't necessarily make people feel better. They might help people live longer, but at a cost, at the cost of quality of life, and may have a lot of symptoms. Many of our therapies, including ARNI, ACE inhibitor, beta blocker, SGLT2 inhibitors, they all improve quality of life. They're all associated with better decongestion, keep people outside the hospital. So just because you have a patient who has advanced heart failure and they're headed towards hospice, or they're headed towards maybe a more palliative approach, that does not mean that we should be thinking about stopping these medications. If anything, I think the threshold to continue these medications should be higher, because again, we know that these therapies do have a pretty sizable quality of life benefit. And the way the way to sort of graphically think about this is that traditionally palliative care and cancer therapy have been essentially mutually non-exclusive. But when it comes to what we do in heart failure, so much of what we do is already palliative. That really, I think that there's a lot of synergy between what we do and palliation in general. I mean, is there any better palliative care therapy than diuretics, for example, for patients with heart failure? And oftentimes patients go to hospice and that they're actually taken off of diuretics and essentially are only treated with opioids, which I think is a disservice. Now, this was what I wanted to just briefly discuss a bit about the role for palliative inotropes. This is something that comes up as anyone who's taking care of these patients all the time. So to really address this question, along with a few other collaborators, we wrote this review to just really sort of frame our thinking around what is the role for palliative inotropes in a contemporary heart failure population, and which patients might benefit from them, and which palliative inotrope might in fact be better than the other. So this was a review in JAMA Cardiology. This was led by Sarah Chusey, who is at Northwestern. And I think before we get into palliative inotropes, we have to sort of think about the fact that these are not benign therapies. These therapies come with a lot of risks. Some of them are related to the line itself. So, the PICC lines or the Hickmans can have issues with withdrawal, occlusion, thrombosis. They can actually increase the burden of rehospitalization, because so many patients are having complications with the line, or with associated infections, etc. Certainly there is other aspects too, which is that they can increase the risk for ICG shocks in patients who still have their ICDs on, can cause arrhythmias. Many patients can have heart failure symptoms despite palliative inotropes. And then the other thing is that many hospices do not cover palliative inotropes, so can place an additional burden, both financial but also on the patient and the caregiver with regards to maintaining these. But let's say that we decide that all of that, the potential benefit of palliative inotropes outweighs all of these potential risks. This is the kind of framework that we thought about. So first of all, there are certain Medicare requirements that patients need to have before you can initiate a palliative inotrope. One is that they need to have NYHA4 heart failure. It has to be prescribed by a heart failure trained cardiologist, and the patient should not be a candidate for advanced heart failure therapies. But additional considerations that we brought to the table was, one is there a caregiver available? Because these lines can be, and these inotropes can be extremely hard to manage for patients, especially with patients with advanced heart failure who may have a lot of functional limitation. Whether they're able to maintain follow-up or not, whether the hospice that they're being referred to will actually cover. Do the patients have electricity, refrigeration, a telephone? I mean, these are all really, really important points, because again, these therapies can be fairly burdensome. And then there's also considerations around maintaining the infusion. And personally, one of the big recommendations that came out of this for me was that I think this is one setting in which we really should consult palliative care, and we should be very clear with patients that this is a therapy that we do not expect is going to improve survival, but might improve quality of life. Again, not in all patients, but in some. But it is very clear to make that distinction, because a lot of patients, erroneously believe that this is medication is keeping them alive in some way, when in fact it might not be doing so. And then really, I think that if we're going to start an inotrope, we also need to be thinking about if we need to have, when should we stop, or when should we wean an inotrope? One of the things that I think some hospitals have done successfully is they've developed weaning protocols for hospices or palliative care providers or primary care physicians, especially for patients at the end of life, so that those members don't think that a patient is going to be terminally linked to inotropes, and it gives them some guidance and comfort about these therapies as well. And then also thinking about when is it a good time to withdraw these considerations. Now, one question that comes in mind is always which inotrope is better. And I don't know, I'm a millennial, I'm a 90s kid, so I figured I'd use this Street Fighter comparison between milrinone and dobutamine. And really, once we're thinking about these, if you look at dobutamine, it's a beta agonist, it's very short acting. It can be quite arrhythmogenic. It used to be less costly than milrinone, although now that difference has changed. But I think one of the big advantages of dobutamine is that it is not affected by renal function. Milrinone, on the other hand, is a bit more long acting, which can be very helpful in the outpatient setting where, let's say, patients have a delay between changing cartridges. They don't just that longer half-life can be extremely helpful in that type of setting. It can also help with if you're trying to wean this as an outpatient, because weaning can be gentle just simply because it has a higher half-life. It used to be more expensive. That difference has come together. There's no difference in survival in these inotropes. There's a recent randomized trial in the New England Journal that showed no difference. So putting all these things together, for me, if a patient has normal kidney function, I usually think milrinone is a better option. But again, this only works in highly selected patients. I don't think that for the most part, this should be a routine treatment for folks with advanced heart failure. I wanted to talk a bit about hospice because I believe, and as I'll show, hospice is both underused, and when it's used, it's actually quite poorly used in patients with heart failure. And if you look at, these are data from the CDC database looking at people who die in hospice facilities across the United States. And what you will see here is that this red line is patients with cardiovascular disease, and patients with cardiovascular disease are least likely to die in a hospice facility compared to all other conditions. And really, this again, to me, suggests that we're not, either hospice is not meeting these patients' needs, or we're just not doing good enough as a specialty to refer patients to hospice. And this is particularly important because this is hospice facilities which have the capability to provide more intensive care for patients with hospice, which I actually think is probably a very good setting for patients with advanced heart disease. And so to see such a low uptake rate was quite disappointing. So it is clear that hospice is being underused in patients with heart disease. And to further study the patterns of hospice use and how it's being used, we performed an analysis from the AHA's Get With The Guidelines registry, and Greg was a co-author on this, and it was a lot of fun doing this project. And basically what we did was that we looked at all patients who were in the Get With The Guidelines registry who were discharged from the hospital to hospice. So this ended up being about 5% of the registry, but still a pretty sizable number. And I just wanted to share some of the big sort of the key numbers, the key data that we got from this. So one of the most important things that I noticed was that if you look at the overall registry data, and if you look at sort of your usual sort of heart failure patient in this registry, only about 1% of patients were discharged with worsening or unchanged symptoms from the hospital. But when it comes to patients who are going to hospice, that number was 35%. And to me, what this means is that we're setting these patients up to fail. That if we were unable to control their symptoms, and in fact, if their symptoms got worse while they were in the hospital, how is the hospice team going to deal with it? How is the family going to deal with this? I don't think that we're setting them up for success. So from my philosophy is that if a patient is, especially if a patient is going to hospice, then I double down on my efforts to make sure that we get them as dry as possible and in as good shape as possible before they go. Obviously not always something we can achieve, but certainly something that I try and do as much as I can. Now, this was really sort of key number and pretty shocking. So hospice is a service that's been designed for patients with an estimated survival of 6 months. And yet, if you look at the median survival of patients who are with heart failure in this entire registry who were sent to hospice, their average survival was only 11 days. And in fact, of these patients, a quarter of patients actually died within the first 3 days. So you can imagine how traumatic this can be, both for the hospice team, but also from the family, that these patients are literally in the throes of death at the time of discharge, which certainly suggests that, again, even when we make the decision to send patients to hospice, we're doing it with patients who have worsening symptoms and are really too close to death. And really, I think the key is that we need to be thinking about this earlier. And then the other interesting thing is that if you look at the medications that patients are discharged to hospice on, a lot of these patients are medications that really the patient should not be on. About 27% of patients were on statins, almost 40% were discharged with an aspirin, 21% were getting diabetic therapies. Now, again, we've talked about the role for heart failure therapies as improving quality of life, but what really this shows is that there's this disconnect that the discharging team has about the survival of these patients who, again, just to repeat, only live for an average of 11 days. It's another slide I'll skip. Now, this is a really key thing. I think if there's one takeaway you can take from this, it's this. So ejection fraction does not predict survival in older heart failure patients. Now, this is basically was shown very clearly, again, from the Get With the Guidelines registry, and in our paper, it was the same thing. This is a paper led by Kevin Shah, but also was shown in our paper, that regardless of ejection fraction in the older patient with heart failure, so Medicare beneficiary who is hospitalized with heart failure, on average, they only live for about 2 years, 2.1 years, and that this was essentially the same whether you were mid-range EF, low EF, or preserved EF. I think a lot of clinicians, especially non-cardiologists, can focus on the EF, and if they see low EF, they think that that's a death sentence. That's certainly not the case, but we also make the other mistake, and we think about, oh, this patient's EF is normal, maybe their heart failure is not that bad. Both of those are incorrect. Really, it is all the other aspects of the patient's health, end organ function, their blood pressure, their state of nutrition, ability to tolerate medications. Those things are much more predictive of prognosis than ejection fraction. One other tip is that home may not be the right place to die for some patients with heart failure. Now, we've already mentioned that the majority of patients and people, when surveyed in the United States, if you ask them where they would like to die, home is almost always what the majority want. And in this analysis from the New England Journal, we found that in 2017, for the first time in modern American history, more people are dying at home than any other single location in the United States, which again, most of this is because of hospice, because hospice has now provided a service which allows us to send these patients with a service that can allow them to die at home. But yet, even when you look at this analysis, the patients who are least likely to die at home were patients with cardiovascular disease. And we've shown this separately in this analysis in JACC. And there can also be differences by cultural preferences. So this was a subgroup analysis from the Palliative HF trial. This is a trial of patients with advanced heart failure who were randomized to palliative care intervention. And because this was a trial, access to palliative care really is not an issue here because the groups were randomized. But when we looked at patients who were African American and versus patients who were white to see where these patients died, and if you see that overall, many more patients were likely to die in home or hospice, but that proportion was much lower for African Americans. Some of that is because some of them may not have the supports at home to be able to do so, but some of it may be cultural, that maybe they don't want to associate their home with a place that they would like to they die at. And so that's why I think a cookie cutter approach to patients with heart failure with regards to end of life is really something that should not be done, and we should really personalize and individualize our approach. Another reason why home may not be the right place, and again, these are data from the Health and Retirement Survey, shows that patients who have heart failure, who die of heart failure, compared to patients who die of cancer, are much more likely to have difficulty with ADLs and IADLs in their last year of life, whether it's walking, being able to go to the toilet, getting in and out of bed, taking their medications, or eating. You can see that those proportions are just way higher for patients with heart failure compared to cancer. And the other thing that a lot of our patients with heart failure lack is that they're much less likely to have informal caregivers or caregivers at the end of life. We've shown that about a third of patients with heart failure who actually live alone. So that's another thing to keep in mind about what the patient's home situation might be, what their functional status might be, because we know that heart failure patients tend to have just much poorer functional status in general. And the last tip that I want to share is that, as a heart failure cardiologist or as clinicians taking care of these patients, so many times our focus is so laser focused on the heart failure that we forget that heart failure is just one piece of a much bigger puzzle. Now, to illustrate that, this is a analysis from the Rehab HF trial, which is a trial, which is an NIA-funded trial of an exercise intervention for patients who were in the hospital with heart failure. And this was some of the baseline data from that trial, but I think it does show in which we looked at patients with HFrEF and HFpEF. But I think this gives you a very good sense of just how impaired our patients are and what are the challenges that they face. So this is a population on average 72 years, very large proportion of patients were Black. You can see that regardless of whether you have HFrEF or HFpEF, these patients had many comorbidities at baseline, although HFpEF had slightly more, but again, I think 6 or 7, both of those numbers are quite high. And in fact, if you look at quality of life metrics, and if you look at physical function, so you see the SPPB score or the 6-minute walk test, those numbers are very similar between patients with HFpEF and HFrEF. But if you look at quality of life, it was worse for patients with heart failure. And if you look at depression, that was higher in patients who had HFpEF as opposed to HFrEF. And I think one of the reasons is because we just have more therapies that improve quality of life for patients with HFrEF, but not so much for HFpEF. But regardless of whether you have HFpEF or HFrEF, patients with heart failure who are in the hospital have significant physical impairments. 1/4 of patients, again, these are patients who were ready to go home. These are patients with a planned discharge to home. These are not patients going to nursing home. These are not patients going to rehab. And as you can see from the average age, these were patients who were actually slightly younger than the average patients who were in registries. But even these patients who are going to go home, 1/4 of patients were unable to stand even once from a chair without assistance. 1/3 of these patients were unable to perform a tandem stance. And 1/2 of these patients met formal criteria for physical frailty. So patients with heart failure have severe functional limitations. But it's not just that. 4/5 of these patients had mild or greater cognitive impairment. This is despite the fact that patients with dementia were excluded from this, or with obvious cognitive impairment were excluded from this study. We found that about 2/5 of our population had unrecognized depression on top of the 16% who did have a formal diagnosis of depression. And then this is really one of the most important numbers. These are patients who are going home, yet 1/3 of them lived alone and had no social support whatsoever. And one of the reasons why these patients are just much more challenging in general is that if you look at the age at time of referral to palliative care, the average cancer patient is 68 years, but the average patient with cardiovascular disease is 78 years, so almost a 10-year difference. And this is why I think when we think about heart failure and palliative care, we really have to incorporate geriatrics to a much greater extent than it traditionally has been, because again, almost all these patients have a geriatric syndrome. Now, before I sign off, I did want to talk about another aspect of patients with heart failure that I'm very passionate about. And that really is financial burden and toxicity in patients who have cardiovascular disease, specifically heart failure. Now, traditionally, when we think about financial burden or distress, we often always think about patients who have cancer. And part of that is because the focus is so much on these sort of high-end biologics that can be extremely expensive. And so I think when we think about which patients are more likely to be financially distressed, we almost always think about patients with cancer. And yet the data that and some of these studies that I've been involved in actually don't show that that's actually not the case. This was an analysis from the nationally representative MEPS data. So these are non-institutionalized patients, which shows that patients who had a diagnosis of ASCVD compared to patients who had a diagnosis of cancer were much likely to have financial toxicity, were much more likely to have difficulty paying medical bills, and were also unable to pay a higher rate of unable to pay any bill. These patients were also much more likely to have financial distress, cost-related medication non-adherence, food insecurity, and to delay or forgo care because of cost. So this is something that I think is also at play with many of our patients. And the question is, well, this is ASCVD, what about patients with heart failure? And so so this was a study that looked. So this is again part of the this paper that we've analysis we've done from the Health and Retirement Survey, in which we looked at patients who either die of cancer or heart failure. We have a third group of patients who have heart failure and a history of cancer. And if you look at the total out-of-pocket cost in the last year of life, what you see is that on average, patients who die of cancer or heart failure have an equal, and we did the testing, there's no difference, paid $10,000 in out-of-pocket costs in the last year of life. And if you look at the standard deviations, that's about 30,000, which means that a lot of the patients are paying even more at the end of life, at a time when people can't work, when people don't have employment. And yet the big difference between patients with cancer or heart failure is that if you look at their wealth, patients with cancer, often because they're younger, often because they're coming from a somewhat better socioeconomic background, have much more wealth than patients with heart failure, which is why patients with heart failure actually are much more likely to have financial burden when they are at the end in the last year of their life. So to summarize, heart failure is an increasingly common condition with a rising mortality rate associated with widespread physical and quality of life impairments, a chronic, progressive, incurable condition with limited life expectancy, and the crushing burden of symptoms and healthcare resource use, and therefore is a perfect condition for palliative care. And I hope that you'll take these tips, which I'm going to recount again, and use them to provide better access to palliative care, better earlier access to palliative care for patients. And just to recount them, prognosis is unpredictable in heart failure, but the surprise question can help you and your teams and your patients help make medical decisions. Have thoughtful discussions about ICDs in terminally ill heart failure patients. The right time for palliative care is earlier than you think. Heart failure patients have burdensome symptoms beyond dyspnea. Many heart failure therapies improve symptoms and quality of life, not just survival. Selected patients may benefit from palliative inotropes, but again, this is a very small number of patients, and if we are to consider it, we have to think about what the burden of this therapy is. Hospice is both underused and poorly used in patients with heart failure. EF does not predict survival in older heart failure patients. Home may not be the right place to die for some patients' heart failure, and that heart failure is one piece of a much bigger puzzle for these patients. In my side life, in addition to research and clinical care, I'm also a writer, and so this crisis that these patients with heart failure face has been something that I've cared about and I've expressed not just in the research world and in talks such as this, but also in some of my writings. And oftentimes my mind goes back to this one story. I was taking care of a wonderful old lady who had heart failure, and whose only wish was to be able to go home. When I called hospice, they refused to believe that she had less than 6 months to live, but they were wrong. She passed away in less than a week, alone in the inert expanse of her hospital room. While I failed to help her achieve her goal, we need to do much more as a health system to help patients with heart disease to the very end. And I'm proud to say that I think of all the cardiovascular subspecialties, heart failure specialists think more about palliative care and end-of-life care than almost any other, and are at the forefront of thinking about how we can make things better for these patients. So I'm going to stop right there. Thank you to all of you for attending. I'm going to stop sharing my screen. I would love to see if you all have questions for me.
Haider, thanks for that really terrific talk and coverage of your work in the field. In trying to guide patients in this journey towards beginning to think towards palliative and end-of-life care, how do you think that handoff should occur with the palliative care team? Should be integrative? How should the patient's primary cardiologist or heart failure cardiologist sort of play a role once the thought occurs to engage a palliative care team?
Yep, I mean, that's such an excellent question. I think that it has to be an integrated model. They have to feel like they're part of the team. I think as soon as, a lot of times, many of these patients that you've taken care of, that I've taken care of, they come to see us as their doctors. They come to see us as their treating doctors. And if they feel like we are abandoning them and there's this new team coming in, they feel a lot of distrust. And so I think that handoff is very, very important, and it can happen in many different settings. And we've implemented some of these programs. So, one of the things that happened that at the Brigham, there's this inpatient team called the Heart Pal team. And so this is a team that comprises a palliative care NP, a palliative care attending, and a social worker. And they so on Mondays, they always round with us. They see all the patients. They're seen as part of the team. And then off our team, we'll say, okay, this patient will benefit from you. This patient will benefit from you. but they are always seen as a part of the team. The other thing that I use is that I think words really matter. And I think for a lot of patients, the word palliative, they don't understand it. It's actually, if you think about it, it's a very technical term. It's something that, the jargon that we've developed, and many clinicians don't understand it as well. There have been studies to show that the term supportive care is actually much better understood. So whenever I talk to a patient, I tell them that this is the palliative and supportive care team, and I always emphasize the supportive care team, and that they are working with us. They're not working, they're not replacing us in any way. That's worked. And the other thing that we've done, this is at the VA, is that we've developed a virtual clinic for advanced care planning for patients. We call it What Matters Most. This is a clinic only for patients with heart failure. And we've developed specialized scripts that we will essentially learn and read out to the patient when we're referring them. And then the palliative care clinician is going to read out to them. And again, the goal is for the patients to never feel like, oh, this is a replacement for the heart failure team, but that they're actually an added layer of support. And I think that many palliative care physicians don't like this rich debate in palliative care about the terminology, but there is randomized trial data showing at MD Anderson, they changed the name of their service to supportive care oncology, and that both increased referral rate, also it improved the timing of the referral as well. So patients were much more likely to get an earlier referral with that name change. So that's one tip that I use for patients.
Any other questions for Haider?
Stunned silence.
Well, you covered it all so beautifully. So let me thank you for the really outstanding presentation. Continue to admire the fantastic work that you're doing. Look forward to some further opportunities to collaborate, but this was really helpful.
That would be amazing. Thank you, Greg, and thank you others for joining. Take care.